I'm Jay Watson with Emory Brain Health Center, and I'm joined today by Dr. Jay Varkey, Associate Professor of Infectious Diseases at Emory University School of Medicine and a hospital epidemiologist. Dr. Varkey, I can't thank you enough for being with us today to take all of the questions as they come in over the next half hour or so.
No, my pleasure, Jay. Thanks for having me.
I think I'd like to start off by asking you if you could paint a picture of how we are doing in Georgia right now.
Yeah, so it's an important question, and I guess what I would say is that we should be doing better. Every day we continue to have anywhere between 3,000 and 4,000 new cases and of COVID-19. And after a period of time from the spring when deaths were decreasing, we're seeing an uptick in deaths and other serious complications from COVID-19. And I think that's one of the take-home messages that I keep reiterating among the people that I work with in the hospital, but also in the community, is that the decisions and the choices that we make in society today will have a direct impact on the number of people who get hospitalized 2.5 weeks from now. So to specifically answer your question, we've been flat, meaning that my hope is that these 3,000 to 4,000 new cases each day represent a peak, but that is way too high. And we have to get better control of it if we're going to be serious about addressing this pandemic and getting more towards a new normal rather than what's happening now.
Great, thank you. We're going to go ahead and begin getting to some of the questions. Several came in early. No surprise, there are a lot of questions concerning schools as families are getting ready to go back and testing. So in no particular order, I'm going to begin with the first one. I'm reading that U.S. testing for the coronavirus is dropping because people are tired of waiting to get tests or weeks for results. What I want to know is, how does less testing impact us?
Yeah, great question. I think the easiest way I would say it is that if we go back to less testing, then we go back to flying blind like we were in late February and March, which, just to paint that picture, in retrospect, there was almost certainly community transmission of COVID-19 going on in Metro Atlanta in mid-February. And again, just to give an exact specific example, if you look at some of our first cases that were identified at Emory University Hospital, where I practice, they weren't necessarily folks who were traveling from China or from Italy. These were folks that were actually working in Atlanta that didn't have a link, which means that they were infected by someone else in Atlanta. The reason we were late on capturing that transmission is because we were so limited by testing. The Department of State, despite the Department of Public Health for Georgia, despite a lot of concentrated effort, only had a limited amount of tests that they could perform on a daily basis until all the other labs could catch up. So I understand the frustration. I understand the lines. I myself have gotten impatient in terms of waiting on results, not just for patients who are getting tests in the community, but also for some of my coworkers. But we have got to find a way to get our testing situation fixed, because otherwise we're going to be flying blind and not being able to actually do what is critical to addressing this pandemic, which is identify, contact trace, and to isolate.
Next question. What are your thoughts on some schools in Georgia restarting and not requiring masks and already dealing with COVID cases? A lot has been reported even nationally out of Cherokee and Paulding counties.
Sure. No, very relevant question, one that hits home for me, not just as an infectious diseases specialist, but I've got 2 kids that were supposed to be starting school on Tuesday, and they can't. And I think that was the right decision that was made by, in this case, City Schools of Decatur, because of the degree to which community transmission is still ongoing in Georgia. And again, I think that's a take-home point. If we want to maximize the safety of in-person schooling, which I think is really the best option for most people, then we have to better control community transmission. When there's widespread community transmission, it makes it that much harder to do in-person school safely. To get to one facet of it, I believe, based on the data we have, and also the experience we've had dealing with taking care of people in a hospital, which in some ways is a little bit of a microcosm of school.
Right.
that universal masking is key. And the reality of it is that I believe that most children should be able to wear a mask. I think it is unfair to the staff that run a school and to the teachers to have masks optional for students. And again, we don't have to recreate the wheel on this. If you look at countries that have done this right, and again, there's no situation here where this is a no risk endeavor. But if you look at what they did in Singapore for very young children that may have more difficulty in terms of wearing a mask for either behavioral reasons or size reasons, they put a full-facing face shield on them, which some small children, like for example, those under the age of say 10, might find easier to wear. But I want to be key on here is that I don't think that the focus, I think masks and face shields are just one part of it. I think the real key in terms of trying to make schools safe is to try and actually address the transmission that's occurring in the community.
Well, a question that just came in pertaining to schools is my kindergartner will be starting in-person school and they're requiring masks for all kids and teachers. If someone who has COVID is masked, what are the risks to others in the room that are also masked? What is the rate of transmission when everyone is masked? What is the safe number of masked children in a classroom? I know that's a lot in that question right there.
No, but it's a great question, and I'm gonna talk in generalities because the reality is we don't have hard data to put a finite number on it. But I'll give a couple examples. We know, not just from our experience, but also going back to data that came from China at the beginning of this pandemic, that the biggest risk for acquiring COVID is having someone in your household with COVID. That is to say, your transmission risk is highest if you have a spouse, a significant other that you share a household with, that you share a bedroom with that has COVID. But the transmission rates there are not 75% or 90%. They actually are closer to between 10 and 20%. Wow. So I've seen many patients, including some employees, where you almost have a discordant couple. You have, say, a husband that tests positive, but a wife that does not. And that's in very close quarters. So then you extrapolate that into a social situation with other people. So a classroom. I tend to think of a classroom essentially like what I see when I walk around the hospital. And in that case, I actually believe that universal masking takes a transmission risk of a lot of people gathered together indoors where that risk might be 10, 15%, and probably decreases it to less than 5%. And if people are really universally masked reliably, probably closer to 1%. So I'll give you just one last example that might help answer the question. We sometimes get surprised with a patient where they don't have symptoms. We're waiting on a screening test, and that screening test comes back positive for COVID. If that patient is masked, we don't consider that an exposure to our healthcare workers. And I think that that's a good example in terms of why universal masking really should be the norm, in my opinion, for most schools, but also for any public setting.
What would be your concern with the schools that are not requiring masking, with some of the photos that we've seen online with hundreds of students in a closed area? I mean, as an epidemiologist, you see that and think what?
I tend to think about a failed bubble. And I'll tell you what I mean by that. If we want schools to be safe, we have to do what, to date, they've done successfully in terms of restarting the NBA, which is really try to make school a secure bubble. In order to do that, that takes collective action. And if you've got 1, 2, 10 people who won't do their part because you walk into that school, you don't know whether you might be an asymptomatic carrier and a transmission risk to others. I think without having universal masking, that makes it really difficult to maintain a bubble. I think your bubble bursts. And then the question becomes, a real one where, how do we prevent infections? And then it's not really an issue, will there be an infection occur at school? It's a question of when there's an infection, what are the next steps? Yeah. So I really do think, I know it's hard, but it's like, these are the difficult decisions we need to make if we want to start, something that's really an emphasis for all of us, which is school.
I'm going to move on to a couple other questions. We are continuing to get a lot of specific school questions when I get to a couple other things, and we'll circle back. You mentioned the NBA bubble. One of the questions is, After seeing all the issues with Major League Baseball, do you think the NBA bubble is the model for how it should be played? And throwing in another question, do you think college football will make it through the newly shortened seasons?
Yeah, great question. I will say to date, and I say this hesitantly because again, it only takes one or two people to burst a bubble. But I'd say to date that what the NBA has done is actually a good model and is working so far. But again, it only takes a few players to kind of burst that bubble, and this may cycle badly. But so far, I think that they've been able to execute what they intended. This may be difficult for folks to hear, especially down in SEC country. But from an epidemiology standpoint, I do have concerns about the college football season. I think football's hard. I think it's more difficult to actually set up a bubble of a team of, 40, 50 people, not to mention coaching staff, trainers, where the nature of the sport is close, unremitting contact all the time. I think that makes it different. And similar to baseball, I think that the idea is unless you have everybody bought into this, anytime you gather people together, you disperse, you basically are entering and exiting that bubble. And that introduces risk. And I tend to think about a team clubhouse the same way as I would an indoor restaurant, a bar, a club, any of these indoor areas that have the risk of being a super spreader event, where you can have not just one person who's exposing one other person, but one person that could potentially expose 15, 20 more people. And I think that makes it really challenging to restart sports in the way we traditionally think about.
Are Emory hospitals and Emory doctors and communities using hydroxychloroquine, azithromycin, zinc for their patients?
We are not. And that's the short answer. The longer but still short answer is that we are following FDA guidance, recognizing the fact that to date, there is no robust data to show that hydroxychloroquine is a effective treatment for COVID-19. To be fair to the question, at the onset of this pandemic, absolutely, those were individual decisions that were made before we had that data, where we would go through risks and benefits between a doctor and patient and occasionally offer. So we have had patients in March and April who have received hydroxychloroquine, but to date, that is not in our treatment guidelines, and we are not recommending that for our patients.
What do we know about after effects? I'm assuming this question is after effects of after getting over COVID. It seems that we're learning more and more about that every day in adults and in kids.
Great question. The real answer, Jay, is there's more we don't know about post-COVID syndrome, and it's got other names to it too, but basically that recovery period after COVID than what we do know. I will just go head to toe and tell you I've seen and heard from both, again, colleagues as well as patients, a whole litany of different side effects that range from confusion, cloudy thinking. We've had some people who've had prolonged periods of time where they've had their sense of smell or sense of taste distorted. Among those who have severe COVID disease, had people who have significant hits to their exercise capacity. So you have lungs that are scarred, that are damaged. That doesn't mean it's irreversible, but for some people with severe COVID, it may be. And then there was a pretty provocative study that came out a couple of weeks ago that actually did imaging. So they took pictures of people with COVID. And if you looked at their heart, there was radiographic evidence of heart inflammation. So the reality is that I think we should expect, and this is another critical reason why we have to get containment of this pandemic, is that it's not good enough to say, well, 85% of people who get COVID-19 have a relatively mild illness and won't require hospitalization. That is true, but we don't yet know enough about the long-term effects of it, which is why we have to be vigilant.
I've heard we are pinning too much hope on a vaccine, that it won't solve the issue of COVID. If we have one by January, how long until we can get it? And if I get it, am I protected and can go about living my life?
Oh, great question. A lot of facets to it. So I'm going to try and thread the needle because there's a lot of different parts of that and a lot of nuance as well. I do believe that there's a reasonable chance that by the end of this year, we may have one or potentially two of the vaccines that are currently in phase 3 studies that, based on that preliminary data in probably about 25 to 30,000 people each, that those vaccines will be deemed to be safe and effective. But I think it's important for society to recognize what that means. When we talk about effective, that doesn't necessarily mean that you essentially have a force field around you and that you're not at risk for getting COVID. What I would still consider a win is that if it actually prevents people from developing serious complications of the virus. Remember, before COVID-19, we had seasonal coronaviruses that essentially caused common cold type symptoms.
Right.
If a vaccine did that, we would call that a win. But to the questioner's point, I want to be careful not to oversell a vaccine. I think this push to develop a safe and effective vaccine is just one phase of it. There's going to be huge considerations to how to deploy that in a way that is fair, in a way that is rapid, and in a way that actually engenders trust. So one of the conversations we have to have right now is addressing the population, many of which are probably tuned in right now, who are hesitant about what is literally an experimental vaccine. We need to start having those conversations on what people's fears are and what they need to know in order to be open to this vaccine. Otherwise, it doesn't make sense to say, yay, we have this moonshot and have identified a safe vaccine in less than a year. That's amazing. If 30 to 40% of people who should receive it refuse.
Right.
And the time to start engendering that trust is now.
I'm supposed to get an endoscopy and colonoscopy on August 13th at a surgery center. How safe is it to have something like this at a time like this?
Yeah, it's a great question. I think, like anything, any intervention has a certain amount of associated risk. To the question about an endoscopy, or I'll even include it in a colonoscopy, I think at an ambulatory surgical center, it's actually relatively safe. I think most medical centers have come out with policies and procedures that are really focused on safety for both the patient, the staff, and the provider doing the procedure. What I would recommend is that person ask the question, what are the specific safety precautions? What I would look for would be, in some cases, some ambulatory surgical centers may require testing of patients before proceeding with the procedure. That's for the safety of the staff. But it's also the idea that if a patient tests positive and if it's not an emergent procedure, maybe that procedure should be delayed.
Right.
The other thing that I would expect is that most ambulatory surgical centers will require that you as a patient arrive masked. If you're not masked, you will be given one. They may ask that if you have somebody that drives you there, they may not be permitted to enter the ambulatory surgical center. They may be asked to wait in their car or in a separate waiting area. And the staff themselves will be wearing personal protective equipment, both to protect themselves as well as to protect you.
What if your 14-year-old has asthma and has been in the hospital almost every year because of the change in weather, but if they wear a mask, he starts wheezing? That's difficult.
That's very difficult. Couple things with that. I mean, and again, I'm going to answer this both as a doctor, but also as someone who's had lifelong asthma. Asthma is tricky, and people have different triggers. What I will say is that this is the time to really work closely with your pediatrician and make sure that that 14-year-old's medical therapy of asthma is being maximized. It's kind of the same reason why I advise coworkers who have bad seasonal allergies. In March and April, that was the time to make sure you are treating your allergies appropriately, because you don't want to be working thinking that you're working with seasonal allergies when in fact you have COVID.
Right.
Mask triggering asthma is tricky. I'm not familiar with that. I think that there are probably masks that are low lint, that are allergen free, that might be less risky of triggering somebody's wheezing. But I think that those are all appropriate questions to kind of work with your pediatrician's office.
I'm due in a couple of weeks. If our families can't do a 2-week quarantine, how long should we tell them they have to wait before holding our baby?
Yeah, that's tricky. I think that there's a medical answer to that, but then there's also sort of a family answer in terms of what people are comfortable with. So I'll try and address the medical parts of it. I think if you had visitors that were unable or unwilling to do a 2-week quarantine and they were entering your home, I think there'd be a couple parameters on it. I think one is that I would personally ask any person that was holding this child to make sure that before doing so, that they wash their hands and that they're masked. I would also make sure that they don't come and visit when they're sick. And if they are unable to quarantine for 2 weeks, I would make sure that any family members that you have understand the fact that to the best they can, if they can't do a 2-week quarantine, that they're taking their appropriate precautions prior to the visit. I want to make sure that I'm not inviting, I'll just say, the crazy uncle who can't follow the rules, who insists on going out every night to a bar or dine-in restaurant,
Right.
or they themselves have friends or people in their family who are at high risk for COVID. Because when you bring in people into your household with a new baby, you're basically bringing in them into your bubble.
Right. What do you suggest when you're in a situation where you're wearing a mask, but others are not, like in a business meeting? Is it okay if everyone is more than 6 feet away, but also inside? You know, we've gotten this question a lot pertaining to different scenarios, you know, from this is a business meeting, but we've had that question regarding grocery stores when you're masked, but others are not.
Yeah. That's a difficult situation, but I'll give a couple things you can do. So yes, to the most you can, spreading out in an indoor office setting is ideal. And it gets back to something that Jay, that I think you mentioned earlier. Yes, I'm a big proponent in masks, but I think we need to be careful not to say that masks alone are the solution here. Remember, the CDC and other public health officials are pushing this message of the 3 W's, which is watch your distance, wear a mask, and wash your hands. And I would actually go in that order. I think distance helps us. So if you're in an indoor setting with a lot of people who can't or won't wear masks, yes, they should be distanced. The other thing that I think for if you're trying to protect yourself, that could be of help is something that, again, public health authorities are pushing out. It's something that we've done in the hospital, is offering eye protection. Remember, the idea is there's different portals for the virus to infect you, and it can affect your mucous membrane. So that's literally your eyes, your nose, and your mouth. We don't know exactly which of those areas contributes to an infection, but I think that wearing safety glasses or even wearing a full face shield is something that we've offered to all of our medical staff, because we know that it's difficult to reliably mask our patients 100% of the time.
Are there any recommended vitamins or over-the-counter meds to strengthen our immune systems to help prevent complications from an infection? I know we've had people ask before about vitamin D, about cardiovascular conditioning. Is there anything folks can do?
The best advice, Jay, is to kind of take care of yourself. So no, there's no over-the-counter supplement or vitamin that I think is going to protect you from COVID or COVID complications. However, I would say maintaining your health during this pandemic is important. So to the best you can, eating a balanced diet, exercising is actually important in terms of reserve. And that, I know that sounds like something any doctor would say, but I will say that there is an increasing body of data to show that people who are obese may be at higher risk of developing serious COVID complications. So I would say that rather than rely on a vitamin or over-the-counter supplement, it's really about taking care of yourself so that if you're unlucky, that you're in your peak health and are then at lower risk for developing a COVID complication.
What is the latest research on contracting the virus multiple times? Is that possible?
Great question. To date, there is no robust evidence to show that anybody can get reinfected within the first 3 months of an illness. And this is really important information because we, in our hospitals at Emory, are actually pushing to stop retesting people who have already been diagnosed with COVID. The disease really seems to be one where people may be contagious for the first 10, 14, maybe 20 days of symptoms. But at that stage, no person to date in this pandemic has been shown to actually be infectious beyond that period. And if you look at a 90-day window after an infection, no person has actually been shown to actually have a reinfection with a virus that's contagious to other people. Now, the reason why I say 90 days is that, again, in the United States, we're only a few months into this pandemic, but it's also related to immunity. So if you look in terms of antibodies that form from other coronaviruses, and again, immunity and antibodies get complicated in a hurry, but we know that those antibodies are present for at least 90 days. And to that end, I actually think that it'd be highly unusual, and to date, again, has never been demonstrated for somebody to be reinfected within that 90-day window of their infection.
Interesting. This is a question I've had for some time regarding hand washing. I don't think I've heard anyone mention using a nail brush. I use one not every time I wash my hands, but at least once a day. Thoughts on this?
I think it's a clever idea. If you look at, and these were some of the information we identified at Emory after we cared for Ebola patients in 2014. We realized the gaps in terms of where people miss their hands when they clean their hands. Under the nails is one area. Is a nail brush necessary for that? Not necessarily. There's a great video that actually, if you Google it, you can find it on the WHO site. There's a couple areas that show good hand washing technique. The World Health Organization has one that actually addresses the idea that as you clean your hands and you have soap and water, if you're running your fingernails kind of on your open palm with soapy water, that's one way to address those areas of the nails. If you have longer nails, and if you're cosmetically okay with it, this might be a time to actually consider trimming your nails. But in the absence of that, actually a nail brush could be helpful. I don't think it's absolutely mandatory, but I like the idea in terms of not just cleaning your hands, but cleaning them well.
A family member tested negative with a rapid test going into the ICU in the hospital for respiratory distress and later died of an infection and pneumonia. He was getting better, then his heart stopped. What are the odds it was really COVID?
Difficult to answer.
Yeah.
The tests that we have, whether they're rapid or not, are good. But the reality is that there's no test really for any infection that has what's called 100% sensitivity, that is to capture all of it. When we screen patients, we feel reliable that is a way to bring people into the hospital bubble. And I think to the questioner's point, having your heart stop, the complications that occur after that, whether that occurs from a heart attack or from COVID, are profound. So to have what occurs where it's pneumonia, that can certainly happen and has happened, unfortunately, for decades, well before this pandemic. When people code in the hospital, they stop breathing or their heart stops. That's a difficult road ahead, assuming the fact that we could even restart their heart.
Our county does not require masks, only encourages. How do I keep my kids safe from those not wearing one? She wears a mask all day except lunch, even on the bus, comes home and showers every day. Is this enough?
I think that parent, assuming it's a parent or a caregiver, is doing all the right things. But in terms of protecting yourself and loved ones, it really has an impact on who's around you. I'll give an example in terms of with my own children. You know, there's a lot of parents who have had very real conversations with not just other parents, but the parents of the children that they socialize with. Mm-hmm. This is, I think, one of those areas where collective action can actually have a lot of impact. So the same way people talk about like a neighborhood watch to mm-hmm. maintain security in neighborhood, I actually think it's the same thing in terms of a parental watch. You can't watch your child all the time on a bus or in school, but you can watch them outside of school, and you can have an impact and have those conversations with who they socialize outside of school. And if it's age appropriate, I think it's the right time to have those conversations.
Just a couple more questions and then we're going to wrap up. We've gotten several questions today about masks. We always get questions about masks. The one I see right now says most of us have cloth masks rather than disposable. They aren't usually washed after each use. What is your advice for safe use?
I think for most people in society, cloth mask will be sufficient, especially if we can get to a point where most of society is doing this. It doesn't have to be 100%, and we can't let the perfect be the enemy of the good on this one. But I actually do think that cloth masks, that there is an emerging body of data that it will be good enough for most interactions in society. The reality is in the hospital, because again, we're in close quarters, we are trying to prioritize surgical or procedure, essentially medical masks for healthcare workers. I would love to say all of the supply chain issues that we had this spring about personal protective equipment were addressed or resolved. I still had very real concerns about, if this pandemic lasts, of whether we'll actually have enough medical grade masks to kind of keep our healthcare workers safe. Mm-hmm. The other thing that I will just address, because I see this in society where people don't feel comfortable with a cloth mask, is get a bunch of them, have a rotating basis. If they aren't laundered immediately, letting one kind of dry after you use it and having a rotating basis, almost like a Monday to Sunday kind of mask, is not a bad system. And it's actually a good way to kind of keep that safe. One last point to it is that, because I do see people wear medical masks in society, is again, be careful of the masks. One of the masks that we keep our healthcare workers from wearing are N95 masks that have what's called exhalation valves. Mm-hmm. So these have these little squares or circles. That's great for the person that wears them, but the problem is it doesn't protect the people around you, because you're basically blowing out unfiltered air in most cases to the people around you. So again, if we're going to be serious about this is something that we have to be all in on. And I think universal cloth masks are sufficient, and let's avoid the N95s that blow out unfiltered air onto other people.
What about seasonal flu? We're not that far away from seasonal flu entering the picture. What impact will seasonal flu have on what we're already dealing with?
So a couple of facets to this. As an epidemiologist, I am worried about seasonal flu. Prior to COVID, seasonal flu always put strain on our hospitals, but our hospital system in the United States is built to deal with seasonal flu. I'm worried about what the impact will be when we have seasonal flu on top of COVID. So what can we do in society? One, let's get our flu vaccine. Okay, we know for the last 10 years that only about 40 to 45% of Americans who should get their flu vaccine get it. So when seasonal flu vaccine is offered, we should get vaccinated. The second piece to it, and again, I'm cautiously optimistic that this translates to us, is sometimes we can get kind of a sneak preview of what flu season looks like in terms of what's going on in the Southern Hemisphere. So for example, in Australia, their flu season usually occurs during our summer. Mm-hmm. And in Australia, it's actually, knock on wood, been a relatively milder flu season. One other tip from this is that all the things we're talking about, watching your distance, wearing a mask, washing your hands, those are all effective ways to prevent influenza as well. And one of the neat things that we've seen at Emory, one of the only good things that came out of March, April, when COVID-19 was really taking off in our community, is that those interventions that we made at the end of March in terms of to physically distance and to wear a mask and wash our hands, it actually ended our flu season. And my hope is that, again, if we get serious about doing those things and if we can sustain it, that will actually reduce the strain of seasonal flu.
Dr. Varkey, my last question for you comes from one of our watchers who says, what's up with Batman behind him? So we need an explanation of Batman.
Yeah, my wife is going to be chagrined at me talking about this, but the short answer is Batman is an old Halloween costume. After Halloween, that Batman's been in my office well before COVID. During COVID, I was trying to think of a way to message this issue about masks. Because again, I know Tony Fauci's been criticized for this, but I'll be honest with you, I have stood before my medical staff back in March when surgeons would come in wearing a mask or wearing headgear and saying, wait a sec, why are we doing this? The issue is that we were asking the wrong question. Back then, the focus was, how do I protect me? And that was on a setting of massive shortages of personal protective equipment. What we learned, and the reason why I keep the Batman, and I have a sign on the Batman, which is really the message, and the message is, my mask protects you, your mask protects me, our masks protect each other. And I like to have the Batman kind of be a symbol that, everybody can be a hero, anybody can be Batman with those simple steps.
I love it. I love it. I love the mask on him, and I love the message. And we've loved having you today. Thank you for fielding all these questions. We really appreciate your advice and guidance, and we hope that you can join us again for another Facebook Live.
No, my pleasure, Jay. Everyone stay safe.
Thank you, Dr. Varkey. Be well. Everyone out there, take care of yourselves. We'll see you next week. Bye.